This is, standing before us is Steve Smith of Dr. Smith's ECG blog, also the author of the ECG in Acute MI, and I think he has helped the current generation of learners to really explore and discover the nuances of ECG, so I can't wait to hear what he has to say today. Thank you. Please welcome him with me.
Thank you, Brent. Actually, I'm not doing ECGs you cannot miss. I'm doing the false STEMI, non-STEMI dichotomy, which is sort of the same. I have no conflicts of interest, and I come from Hennepin County Medical Center's Department of Emergency Medicine. I'm very lucky to be at this hospital where we have incredible resources and it's incredibly well run, and a department that is just loaded with unbelievable amount of talent and passion among both faculty and residents. So yesterday, the incomparable Amal Mattu talked about who goes to the Cath Lab emergently. And I'm sort of going to be talking about the same thing here, but I'm going to try to take a little bit different angle and maybe send you away with a slightly different paradigm on acute coronary syndrome. Dichotomy is black and white, and we know nothing in medicine is black and white. Yesterday, we learned that algorithms make people stupid. And the STEMI, non-STEMI dichotomy does the same thing. It keeps us from thinking, and that's what we need to do. After I wrote the ECG in acute MI, in which I'd spent a lot of time differentiating subtle ST elevation from no ST elevation and non-ischemic ST elevation from ischemic ST elevation, a cardiologist came up to me and said, I don't know what the big deal is. Either there is ST elevation or there isn't. So he obviously didn't get it and only saw things in black and white. Last week I got an email from a reader. He'd just seen a patient. He was a second-year resident. He said this patient had been previously healthy, had a normal ejection fraction previously, but developed chest pain, had chest pain all night. And when he arrived, he was in cardiogenic shock. His bedside echo showed very poor LV function, like 30 to 35% ejection fraction. This was his electrocardiogram. And he saw lots of ST depression and ST elevation here and thought, well, this is a STEMI, I'm going to activate the Cath Lab. The patient went to the Cath Lab, had 90% thrombotic LAD. It was open, but it was 90%. He had 4-vessel disease with an occluded RCA, a very stenotic circumflex, and an occluded ramus intermedius. He had to go to CABG, excuse me. And in this email, he said that the cardiologist told me this is not a STEMI. And he said, why is this not a STEMI? So my answer to him was, it doesn't matter whether it's a STEMI. Does anyone really care if there's 1 millimeter or 2 millimeters of ST elevation there, or 1.5 or 2.5? Does it matter? Is there anything in biology that follows a rule like if it's 2.1, it's too much, and if it's 2.0, it's too little? So it doesn't matter if this is a STEMI or not. The patient has a life-threatening acute coronary syndrome with a thrombus in the vessel and has to go to the Cath Lab. This is a patient who came in, had flash pulmonary edema. His blood pressure was 280 over 160, and he got put on non-invasive ventilation and got nitroglycerin dialed up. Now, you got to remember that and let me just point out that there's a lot of ST depression here and here and here, and all across here, and ST elevation in AVR. So there's diffuse ischemia, diffuse subendocardial ischemia, giving ST depression here and ST elevation up here. And so this can be caused either by acute coronary syndrome with poor flow through the artery, or it can be caused by too much demand ischemia, high heart rate, high blood pressure, hypoxia. So you can't tell that. And it can also be initiated either way. Flash pulmonary edema can be initiated by a thrombus, which causes poor cardiac output, catecholamines, more afterload, and a worsening cycle. Or it can be caused by someone who has hypertension to begin with, and they get a little bit of fluid overload or increased hypertension, and they get the same vicious circle, and they can end up like this. You can't tell when you first see them. But you always have to keep in mind that this may be an acute coronary syndrome. And so they treated him with non-invasive ventilation, 250 mics per minute of nitroglycerin, and the guy looked great. So they sent him to the MICU without getting another ECG, and then up there he sat there for a while, and finally he got another ECG, and that was it. And you can see that now there is right bundle branch block, left anterior fascicular block, and massive ST elevation of a proximal left anterior descending artery occlusion. So why was that? Well, as I said before, these can be initiated by a thrombus in the artery that partially occludes it, but thrombi are always active. They propagate and lyse constantly. They are not static things. So anything that partially occludes can fully occlude. This is a spectrum. Here's a 60-year-old male who had chest pain. He came into a hospital at 7 p.m. They gave him, they did this ECG. They gave him aspirin and nitroglycerin. His pain was pretty severe. They gave him morphine. They got a troponin. It was negative. They admitted him to the hospital for a rule-out. He had another troponin at midnight. It was negative. He had another troponin at 4 a.m. It was positive. So they said, OK, he's having a non-STEMI. Let's get him set up for cath. The next day, they put him on enoxaparin. They put him on a P2Y12 inhibitor. And then when they finally got around to getting another ECG at noon the next day, this was it. So now he has all Q waves in the anterior leads. That partially occlusive thrombus, which you see there, is now completely occlusive, and he loses his entire anterior wall. And he ended up with a heart transplant and a big lawsuit. Beware dichotomies. Every pathology has a spectrum of severity. And in the case of subendocardial injury, if you have a partially occlusive artery, it's still getting some flow through. It's the subendocardium that is most vulnerable. It's next to the high pressure LV, and it's dependent on little feeder arteries that have to go all the way through that thick myocardium. And in diffuse subendocardial ischemia, like you saw in those previous ECGs, it'll be the whole subendocardium here could be ischemic, and that can also infarct without infarcting transmurally. But that thrombus can propagate and occlude the entire artery, and then you get a transmural infarct like you saw in those cases I showed you. And yet we have the American College of Cardiology and American Heart Association telling us that there's a STEMI or non-STEMI. And there you see their graphic in their guidelines. But ACS is a spectrum. Standard STEMI is mostly high risk, although really an isolated inferior MI with no posterior, lateral, or right is much lower risk than these non-STEMIs I'm showing you. And then there's unstable angina or non-STEMI without high-risk features. And then the people who have absence of ST elevation criteria, but they're high risk. The Thrombolytic Trials done back in the 1980s are the only reperfusion trials that use placebo control. There's never been PCI versus placebo. That's never been done. Those trials enrolled patients who were symptomatic and had ST elevation. And believe it or not, this was poorly defined. To one physician, every physician enrolled different kinds of patients. And they found that patients with this ST elevation benefited from thrombolytics versus placebo. But they didn't look at patients who had MI with less ST elevation. They were not studied. They also, in these trials in the 1980s, studied ST depression. These studies, ISIS-2, JISI-1, late, and TIMI-3B, enrolled, excuse me, but they enrolled patients with only 1 millimeter of ST depression, only 1 lead of ST depression, and they enrolled small numbers of patients, and very few were enrolled at less than 6 hours. In fact, TIMI-3B, the median time to enrollment was 9 hours. We all know that patients who have myocardial infarction, they need to be treated quickly. And yet the absence of positive results from these trials was not attributed to the fact that these were patients who were enrolled late. And this is in spite of the fact that ST depression has very high mortality. This is from Gusto 2B back in 1999, where they found 2 leads with 2 millimeters of ST depression had 14% 1-year mortality versus 4% without ST depression. But that's 1999. Okay, that's a long time ago. How about in the days of PCI and P2Y12 inhibitors and GP2B3 inhibitors and all this stuff we have now? Well, high-risk STEMI versus high-risk non-STEMI. This is 2015 data. STEMI is 15.4% 1-year mortality, and non-STEMI 20%. Non-STEMI is just as bad or worse than STEMI. We've all heard throughout the years, ever since these faulty trials in the 1980s, that fibrinolytic therapy should not be administered to patients with ST depression. However, buried in the 2013 STEMI guidelines, you will find that they say except for patients when a true posterior MI is suspected. Now, this isn't surprising. I mean, it's really a STEMI of the back wall, and you only have leads anterior, so you can't have ST elevation. Or when associated with ST elevation in AVR. Remember, this is not STEMI out here. There's no wall on the top of the ventricle that gives you STEMI here. There's only walls in this direction that give you ST depression. ST elevation in AVR is really reciprocal to ST depression out here. So they're saying now that we can give thrombolytics to patients with ST depression. This is a first. that I've seen, and I think it's right because there's a big thrombus there in the artery, and thrombolytics can lyse it. There are ST elevation criteria we use for these interventions. All use 1 millimeter for the limb leads, but in the precordial leads, there are at least 7 different methods for measuring ST elevation over the years. I'm not going to bore you with them. I'm going to go with the one we have today, which was developed in a study of 1,220 patients, 248 of whom had MI by CKMB, not by angiography. This was not an occlusion study. And they had to have 2 consecutive leads with ST elevation. V2 and V3 were the only ones that didn't use 1 millimeter, and they used 1.5 millimeters in women, 2 millimeters in men greater than age 40, and 2.5 millimeters in men less than age 40. This was only 46% sensitive for myocardial infarction, although it was 98% specific. So 54% of MI by CKMB do not meet this criterion, and 70% of MI by troponin do not meet this criterion. Do you want to only diagnose 30% of MI? I'd like to be better than that. So how sensitive are ST elevation criteria for occlusion, which is what we emergency physicians need to know. We can always diagnose a non-occlusive, low-risk MI by troponin. We need to know which ones need to go to the Cath Lab now. Schmidt and Marty took people who had minimal ST elevation, took them all for angiogram, and he found that it's about 70 to 75% sensitive, these ST elevation criteria. So 25 to 30% of occlusions end up being classified as non-STEMI. And studies of interventionalists in ECGs show they have about 75% accuracy for diagnosing acute occlusion on the ECG. They have low sensitivity, and it's even worse after VFib arrest. So patients who rule in for MI, they have a non-diagnostic ECG, and therefore they're diagnosed with a non-STEMI, and they get they get aspirin and heparin and P2Y12 inhibitor. They go to the Cath Lab the next day. How about them? Well, it turns out that about 25% of them have an occluded artery the next day. Right? You can kind of predict what their outcome is. It's worse than those who have an open artery because they've been occluded there now for the last 24 hours. And so they have higher biomarkers and worse LV function and higher mortality. So the European Society of Cardiology has said the optimal timing of PCI in non-ST elevation ACS has been extensively studied. And we've found that patients who have non-STEMI can wait 24 hours for their cath. And that's what everybody believes and goes by because these are the rules. However, they state in their guidelines, patients at very high risk who have, and this is exemplified by refractory angina, the guy who has ongoing chest pain you cannot control with nitroglycerin, severe heart failure, life-threatening ventricular arrhythmias, or hemodynamic instability, were not included in randomized controlled trials in order not to withhold potentially life-saving treatment. Such patients may have evolving MI and should be taken to an immediate, less than 2-hour invasive evaluation regardless of ECG or biomarker findings. A negative ECG and negative biomarker, you can do it just based on your clinical suspicion. The guy who's sitting there sweaty and holding his chest and has a non-diagnostic ECG and negative troponin. But of course, these are Europeans. I mean, no one in America trusts the Europeans, and especially trials that are done in Europe. So, but we do have our own American College of Cardiology, American Heart Association. They must be more rational about this. In 2007, 2012, and 2014, what do you think they say? The same thing. Refractory angina should go to the Cath Lab within 2 hours. And also patients with hemodynamic or electrical instability or worsening heart failure. Unfortunately, in this time period, the biggest trial of non-STEMI randomizing to early versus delayed intervention was published in the New England Journal in 2009. They took non-STEMI and randomized them to earlier routine PCI and found no difference in death, MI, or stroke. So why am I up here? Well, in fact, what is rarely mentioned is that patients with a GRACE score greater than 140 had a better outcome with early PCI. Okay, but who wants to calculate a GRACE score? Early intervention, however, if you look in the paper and don't just read the abstract, was not early. Median of 16 hours. So you don't want your occlusion to go to the Cath Lab in 16 hours. You want to go in less than 2 hours versus 52 hours. What else about this study? I looked through the methods to find whether they included patients who had refractory ischemia, patients who continued to have chest pain in spite of maximal therapy. And it was not in there. So I emailed Dr. Mehta, the lead author, and he said, quote, "I can't imagine anyone would have enrolled a patient with persistent ischemia." So you've got a patient with undifferentiated persistent chest pain. Unfortunately, it's not usually angina. It's usually non-cardiac chest pain. What do? Well, you have to get the ECG, and you have to be good at reading the ECG. I'm not going to be able to teach you here all that you need to know about reading an ECG, but maybe I can teach you the importance of it. And then there's troponin, which has a good positive predictive value, but a poor negative predictive value. In fact, about half of STEMIs have negative troponins at presentation. Now, this may change with the new high sensitivity troponins. We'll have to see. And finally, just typical anginal pain, a history of coronary disease, and your high clinical suspicion. So these are conditions in the middle of the STEMI, non-STEMI spectrum. There's non-diagnostic ECG, but the patient still has pain, their troponin comes back positive, and the symptoms are ongoing in spite of nitroglycerin. Those patients need to go. Subtle ST elevation that's ischemic. Hyperacute T waves due to ischemia. STEMI equivalence, which, by the way, most cardiologists are not familiar with, so you have to educate them on this. Dynamic ST segments and T waves, which means this thrombus is propagating and lysing, propagating and lysing. That's a very high risk situation. Isolated ST depression, of course I talked about that, how that's now, if it's ischemic and it's refractory, it's an indication even for thrombolytics. Isolated typical angina, which is refractory even with a non-diagnostic ECG or troponin. And then, of course, there's all the problem with the pseudo-STEMI patterns, the LV aneurysm, and the LVH, and the pericarditis, and especially early repol that can fool you. And then you got to differentiate them from demand ischemia or type 2 MI. And another false dichotomy, do we activate the Cath Lab or not activate the Cath Lab? So we've developed a different pathway called the middle way, pathway B, where we call a faculty-to-faculty cardiologist and get them in the ED within 5 minutes. We get a high-quality echo tech, contrast echo. And we activate the Cath Lab if we believe there is an acute thrombosis in a coronary artery causing persistent ischemia that is refractory to medical management. Not if there's ST elevation or not ST elevation. This is why. So you got to base it on history and exam. Never forget pretest probability. Serial ECGs. Real ischemia almost always evolves, but it may evolve slowly. And echocardiogram in the setting of subtle or non-diagnostic ECG. The absence of a new wall motion abnormality and high-quality contrast echo read by an expert essentially rules out transmural ischemia. But absence of wall motion abnormality there can be an absence with ischemic ST depression, especially that global ischemia, subendocardial ischemia. So here's a patient with typical chest pain. And I really can't find any evidence of ischemia on this. But he continued to have pain. In spite of the nitroglycerin we gave him, IV nitroglycerin, it wouldn't go away, and his troponin came back, troponin I at 2.0, and so we activated the Cath Lab. And he had a 100% circumflex occlusion. So circumflex is in the electrocardiographic silent area of the heart, and you can see nothing on the ECG with an occlusion. This is a patient with heartburn, and his doctor thought this was a negative ECG, but in fact, there's a tiny bit of ST depression in AVF here, and a tiny bit of downsloping ST depression in 3. And these are reciprocal to AVL. And when you see ST depression in the inferior leads, it's not inferior ischemia, it's reciprocal to high lateral STEMI. And that's what he had, is a obtuse marginal occlusion. He had a cardiac arrest from his obtuse marginal occlusion, but he survived. 45-year-old with chest pain. You think this looks exactly like early repolarization, and that's what everybody else thought. However, they could have used my formula for figuring out whether it's early repolarization or LAD occlusion, and that formula relies on these pieces of data, which I don't have time to go into with you now, but I'm going to tell you that if you plug those numbers, computerized QTC, ST elevation at 60 milliseconds after the J point in lead V3, R wave amplitude in V4, if you plug them into the equation, and in this case you get a formula value of 23.6, which is greater than 23.4, and indicates that this is a STEMI. This was missed. It was a STEMI. By the way, that equation is on the side of my blog out here, and all of the disclaimers are up here. It's very useful. There's an iPhone app called Subtle STEMI, which you can use. This patient has vague chest pressure. Give you a moment to look at it because it's really diagnostic of inferior MI. ST elevation here, here, and here, which is way below a millimeter, but is associated with ST depression and AVL. And this gentleman had an RCA occlusion. I was in a meeting. I got this texted to me on my phone. I took a look at it. And the text said patient has chest pain, and I said it's an obtuse marginal occlusion. And she says, how do you know that? And I say, because there's ST depression in 3, which is reciprocal to some ST, a little bit of ST depression in AVL, but that alone doesn't do it. It's in conjunction with a bit of ST depression in V2 and V3. So it has to be a posterolateral MI, and it was an obtuse marginal occlusion. This patient is 61 years old and had an hour of chest pain. That's a pre-hospital ECG. And you can see there's kind of big T waves here, and there's an inverted T wave in AVL with a little bit of ST depression. This is really suspicious for an inferior MI. Kind of strange T waves there in V3 and V4. So you got to the ED and had this ECG, and now what you see is some ST elevation in V1. V1 is a good lead to look for right ventricular infarction. And in conjunction with evidence of inferior infarction, it tells you this person has a proximal RCA occlusion. So we got a right-sided ECG, and sure enough, there's ST elevation across the right precordium. He's got a right ventricular and inferior MI. Here's a 24-year-old female who spent all night drinking. She came in with chest pain and vomiting. And she had this pre-hospital ECG, which of course looks like pericarditis because there's diffuse ST elevation all over, right? But there's one problem with that. There's ST depression in AVL, which does not happen in pericarditis. I've researched this and it doesn't. And so this patient got another ED ECG, which showed basically the same thing. And so I activated the Cath Lab, and the cardiologist was upset with me that this must be pericarditis. But we did a stat echo, and it showed that she had diffuse wall motion abnormalities. She had a proximal LAD, wraparound LAD. It goes to the inferior wall. She had an anterior, lateral, and inferior MI, and would have died without immediate PCI, which she got. So those pseudo-STEMI patterns, they may be pseudo-STEMI or they may not be, especially pericarditis. I always say you diagnose pericarditis at your peril. And this is a case that came in just last week, a man with chest pain. This is obtained at his clinic. He was sent code 1 to the ED, but he's got this, if you actually do the equation on it, it's low. He got this ED ECG. We did the equation on it, and again, it came out a low number. And so we did a stat echo. We had no wall motion abnormalities. This was his baseline early repol. And my time is out, unfortunately. I didn't get to all my ECGs. But thank you for listening.
Thank you for everything you've done to move forward emergency department interpretation of ECGs, and for scaring the heck out of me with all of those ECGs and patients that I may have sent home who now worried are having STEMIs. Okay. Eve, do you have any questions from Twitter?
Yeah, one quick question. With all the pre-hospital folks at this conference, how does changing our thoughts from a dichotomy to a spectrum change the systems way that we're going to deal with?
So the patients who are not clearly STEMI I don't see them as requiring a 90-minute door-to-balloon time. If it ends up being a little longer than that, that's okay. You can take the pathway B, is intensive evaluation, takes a little more time for evaluation. And so medics who suspect an occlusion but can't really diagnose a STEMI should just be actively advocate for their patients and tell the emergency physician of their concern and so that we can get the process going faster.
Should they be diverted to a cath center if they're closer to another hospital?
Well, that's a good question. I guess it depends on the skill level of the medic and their confidence. In fact, I've found I interact and email back and forth with a lot of people, and the people who are best at reading ECGs, in my experience, are medics. So they know it better than anybody. Yeah.
All right, so thank you. We will wrap up as we don't want to